So our next presenter is Dr. Jessica Golbus. She is a clinical instructor in the Division of Cardiovascular Medicine. She received her MD from the University of Michigan and completed her residency in internal medicine at the University of Pennsylvania. She then completed her training in general and advanced heart failure and transplant cardiology at the University of Michigan. She also received her MS through the University of Michigan School of Public Health. Dr. Golbus is actively engaged in clinical practice in the areas of heart failure, heart transplantation, and mechanical circulatory support. Dr. Golbus's research focuses on using digital health technology, like smartwatches, to improve the delivery of cardiovascular care and on optimizing treatments for patients with advanced heart failure. Thank you for joining us, Dr. Golbus.
Thanks, Sarah. Great. Well, thanks for the introduction, and it's nice to meet you all, and appreciate your time. I know you were expecting Keith Aronson this morning, which I am clearly not, but this is a kind of shared presentation that reflects, hopefully, at least some of the sentiments that he had wanted to convey to you all today, and then hopefully I can share as well my perspectives on top of that. I have no disclosures. So over the next 30 to 45 minutes, I'm going to talk with you all about congestion and cardiorenal syndrome, management of the difficult to diurese patient, the role of guideline-directed medical therapy in hospitalized patients, and then therapies for end-stage heart failure. So I certainly don't need to remind you all that heart failure is a progressive and insidious disease of peaks and valleys. But as you can see, it is a progressive decline with patients really never recover back to their functional baseline when they've had insults. And you know, that's typically in the form of worsening heart failure and hospitalizations. And we're really focusing here today on the end of that process. Perhaps as a more concrete example here, this looks at the impact of heart failure hospitalizations on mortality. So this is data from a study of over 14,000 patients from British Columbia. And after their first heart failure hospitalization, mortality was about 2.4 years. And mean survival or median survival after the fourth hospitalization was actually 0.6 years. And you can see that after every hospitalization, survival decreases. And I certainly don't want to speak for all of my colleagues, but I would say that many of us are starting to think about whether someone would be a candidate for heart failure advanced therapies as early as after their first heart failure hospitalization. And I think many of us are starting to think about that as soon as they've had at least 2 hospitalizations. So moving on now to congestion and cardiorenal syndrome. So Dr. Aronson wanted to make sure that you all knew that congestion is the disease. It's not just a nuisance symptom, and it's the primary reason for heart failure hospitalization in 85% of patients. And you know, that really acts through 2 mechanisms, so to speak, a fast and a slow pathway. So typically congestion is precipitated by a fairly minor insult, dietary indiscretion. And that leads to sympathetic activation. That sympathetic activation will mobilize venous reservoirs, and that's predominantly through the splachnic vasculature, which serves as a large bed of blood. And so then that vasoconstriction will lead to a rapid increase in effective circulatory volume. Sympathetic activation also acts via a slower pathway, leading to sodium and water retention. And those 2 pathways then act together to increase effective circulatory volume and via a negative feedback loop. And again, increased filling pressures and congestion is not just a symptom. And I think that these 2 figures show that fairly pointedly. So on the left, you can see the association between cardiac index and adverse outcomes. So specifically death, cardiac hospitalization, and transplantation. And you can see that there's no difference in outcomes at 180 days between patients with a cardiac index less than 2 and those with a cardiac index greater than 2. In the right, you'll see that patients are dichotomized as those with a pulmonary capillary wedge pressure greater than or less than 20. You can see an early significant difference in the two groups with respect to clinical outcomes. And so I hope I've convinced you here that congestion is more than just a symptom. It is truly a disease. So cardiorenal syndrome now, that's a spectrum of disorders involving both the heart and kidney, with dysfunction in one organ inducing dysfunction in the other. And this is a really complex and I think incompletely understood process. But the kidney here is really behaving as if there is volume depletion when in fact the patient is volume replete. And it's that process that leads to a decrease in GFR and an increase in sodium avidity. So this is a study here that was done in 2009. It evaluated 145 patients with acute decompensated heart failure who were measured with a PA catheter. The mean ejection fraction was 20%, cardiac index was 1.9, and mean serum creatinine is 1.7. 40% of patients developed worsening renal function, which is a standard term in the literature and defined by an increase in serum creatinine of at least 0.3. So looking here, you can see that percent with worsening renal function is on the y-axis, and then CVP here is on the x-axis. And you can see an increase in percent of patients with worsening renal function by their CVP. And with patients that had a CVP of greater than 24, nearly 80% had worsening renal function. Compare that though to say systolic blood pressure, and you can see that there's no difference across the range of systolic blood pressures in patients that developed worsening renal function. And similarly, really no difference in those with worsening renal function by cardiac index. And in fact, there is greater worsening renal function in people with higher cardiac indices. And so it's really that high CVP state that is associated with difficulty with diuresis, worsening renal function independent of cardiac index. And to show this in another way, the impact of congestion, this was a study by Dr. Metra in 2012 that classified survival in 600 patients based on congestion and worsening renal function at discharge. And they defined congestion by JVP, S3, Rales, edema, and hepatomegaly. And you can see on the top you see on the y-axis is survival and time is on the x-axis. And you can see that the blue curve is patients with no congestion and no worsening renal function. And those patients had the best outcomes. But that's actually not significantly different than patients that were decongested and had worsening renal function. And then in the black and the red curves, you can see those that were discharged from the hospital with residual congestion. So hopefully this can convince you that decongesting patients prior to discharge, even if at the expense of worsening renal function, is associated with improved survival. So how do we diurese these patients that have diuretic resistance, worsening renal function? So diuretic resistance is an incredibly important problem in our population. So in the figure on the left, you can see there's diuretic efficiency per 40 milligrams furosemide equivalent. And the vast majority, or really all of the patients essentially, have diuretic resistance. And that diuretic resistance is across the range of patients with renal function. So I really like the figure on the right, and you can see that diuretic efficiency is almost uniformly low, but it's really irrespective of patients' underlying renal function. So the dose trial really taught us how we can think about diuresing these patients. So the study used a 2x2 factorial design, and it was designed to look at the impact of bolus versus continuous infusion diuresis, and then low versus high dose diuresis. So the low dose group received the patient's home oral dose administered as IV, and then the high dose group received intravenous Lasix at 2.5 times patient's home dose. And the primary outcome for the study were patients' global assessment of symptoms, quantified as the area under the curve on a visual and log scale over 72 hours, and then the change in serum creatinine from baseline to 72 hours. So looking here on the left in change of symptoms, you can see that there's really no difference versus bolus versus continuous infusion diuretics. But then looking at the right, while perhaps not significantly significant with a p-value of 0.06, there was certainly a trend towards improvement, greater improvement in symptoms with use of high-dose furosemide. And certainly while it was associated with improved symptoms, we also looked at whether the impact of, what was the impact of high dose diuresis versus low dose diuresis on change in creatinine. And you can see here that there was no difference in change in creatinine between the bolus and the continuous Lasix, and similarly, no difference in creatinine between low dose and high dose Lasix. So high doses are associated with likely greater improvement in symptoms, and really no significant change in creatinine as assessed in milligrams per deciliter. There was an increase in the percent of patients that did have worsening renal function, and in that you can see on the right. So 23% of patients with high dose Lasix had worsening renal function, defined by that increase of creatinine by at least 0.3 in comparison to the low dose group. Although I hope that I've convinced you based on the prior data that worsening renal function perhaps is acceptable if it allows you to decongest the patient. So the trial did show us additionally that high dose diuretics are also safe. So they improved dyspnea at 72 hours. They had a greater change in weight at 72 hours and greater net fluid loss. And there was no difference with respect to death, rehospitalization, or ED visits in patients who received high dose versus low dose diuretics. And in fact, as you can see on the right, there was numerically, though not a statistically significantly better outcomes with high dose Lasix. So certainly, I hope that I've convinced you that a strategy of increasing your dose and diuretic augmentation through higher doses may be one strategy for diuresing the congested and difficult to diurese patient. Although certainly we have other strategies. So thiazide diuretics act through sequential nephron blockade. So as a reminder, in loop diuretics act at the ascending loop of Henle there. Although you can have compensatory sodium reabsorption at the distal tubule there, and you can see that in number 4. So thiazide diuretics act by blocking that compensatory sodium reabsorption distally. Certainly, there's no placebo-controlled studies of thiazides to date, although they are not benign and are associated with greater hyponatremia, hypokalemia, and worsening renal function. So this here is a retrospective analysis looking at the effect of metolazone on mortality. And so as you would expect, use of metolazone in univariate analyses was associated with higher mortality. And certainly you would expect that in unadjusted analyses, given that we are typically giving thiazide diuretics to our sicker patients. Although the study went on then to do extensive adjustment for comorbid conditions associated with illness severity. And you can see that in propensity adjusted and in a propensity and multivariable adjusted model, metolazone was associated with significantly worse mortality. Contrast that to higher dose furosemide, which was associated in univariable analyses with higher mortality, but did not have any significant impact on survival in propensity and multivariable adjusted models. So what do the guidelines tell us about the difficult to diurese patient? So they give this a 2A recommendation that when diuresis is inadequate to relieve symptoms, it is reasonable to intensify the diuretic regimen using either higher doses of intravenous loop diuretics or the addition of a thiazide diuretic. So what other strategies do we have? Well, there's tolvaptan. Tolvaptan is approved for symptomatic hyponatremia in the setting of volume overload. Although it's exceptionally expensive and really doesn't improve any meaningful outcomes. There's also inotrope assisted diuresis. So this is data from the OPTIME outcomes of a prospective trial of intravenous milrinone for exacerbations of chronic heart failure trial. The study randomized 949 patients with systolic dysfunction and decompensated heart failure to receive 48 to 72 hours of intravenous milrinone or placebo. And notably, the study did enroll patients for whom inotropes were not felt to be mandatory. So there was no difference in worsening renal function from admission to discharge between placebo and milrinone groups, which was the primary outcome. Although the study did find that there was significantly greater adverse events in patients in the milrinone group. So there was a greater treatment failure, sustained hypotension, greater atrial fibrillation, and numerically, though not statistically higher mortality in the milrinone group. So again, no difference in renal function, no difference in decongestion, but greater adverse events. So the guidelines currently give it a 2B recommendation that short-term continuous intravenous inotrope support may be reasonable in hospitalized patients with severe systolic dysfunction who present with low blood pressure and significantly depressed cardiac output to maintain perfusion pressure and preserve end organ function. Although to add on to that, it's not reasonable and not recommended in the overwhelming majority of heart failure patients who are not in a low output state. So moving on now to renal dose dopamine. This is data from the ROSE-AHF trial. And this looked at the role of dopamine at 2 micrograms per kg per min compared to placebo in acute decompensated heart failure patients with a reduced GFR. Overall, the trial was negative for renal, diuretic, and clinical outcomes. So in the first figure on the bottom left, you can see total or 72-hour urine volume. And this was nearly identical for the placebo and the dopamine groups. And then in the figure on the right, you can see change in cystatin C, and again, almost identical for the two groups. So no data here to support the role of dopamine in decongestion. The guidelines say that it still can be considered, although give it a 2B recommendation to use low-dose dopamine with loop diuretics to improve diuresis. So moving on now from a strategy of decongesting the difficult to diurese patient to guideline-directed medical therapy considerations in hospitalized patients. And these are not end-stage patients, but this is the patient with acute decompensated heart failure. So this is data from the RAILS study, randomized aldactone evaluation study. And RAILS randomized patients with class 3 or 4 heart failure with an ejection fraction less than or equal to 35% to spironolactone or to placebo. And you can see very early separation in the two curves as early as less than 3 months. And this was associated with about 30% fewer cardiac deaths between the two groups. So spironolactone works well, and it works early. This is now data from the Copernicus trial, which looked at early clinical outcomes in patients that received a beta blocker. So this was patients hospitalized with acute decompensated heart failure, were randomized to receive carvedilol or placebo. Patients notably had to be off of intravenous inotropes or vasopressors for at least 4 days to be enrolled in the study. Patients that were randomized to the carvedilol group initially started at carvedilol 3.125 milligrams twice a day, and this dose was doubled every 2 weeks up to 25 milligrams twice a day. The study importantly divided patients into all patients into higher risk patients, and they defined the higher risk cohort as those with rales, ascites, edema, multiple 3 or more heart failure hospitalizations within the past year, need for IV inotropes or vasodilators within the past 14 days, and an ejection fraction less than 15%. So there were in the study nearly 2,300 patients in total, of whom about 25% were in that higher risk cohort. So you can see that there were significant decreases in deaths and the combination of deaths and mortality with beta blockers, which is again in red there. And that difference was as early as 8 weeks. We see similar benefits here with early initiation of SGLT2 inhibitors. So this is data from DAPA-HF and from the Emperor Reduce study. So on the left, you can see as early as 28 days, there was a statistically significant decrease in cardiovascular death or worsening heart failure with dapagliflozin. And on the right, with empagliflozin, as early as day 12, there was a statistically significant decrease in all-cause mortality, heart failure hospitalizations, or emergent urgent visits for worsening heart failure. And that difference between those two groups continued to grow and was sustained at 34 days. So what about Entresto or ARNIs? So this is data from Pioneer-HF that looked at EF less than or equal to 40%, NT-proBNP greater than 1600 in patients admitted with heart failure who were hemodynamically stable. So again, these are all hospitalized patients getting initiated on Entresto. And in the figure on the right, their primary outcome looked at change in NT-proBNP from baseline. And you can see at a week, there was a significant and sustained then benefit from Entresto as compared to enalapril. And there was no difference in secondary and safety outcomes. So again, all of these data is showing that early initiation of guideline-directed medical therapy is beneficial here as early as 1 week after initiation from Entresto. So similar data here looking at outcomes with early initiation. So on the left here, you can see a figure looking at hospital initiation of ACE inhibitors or ARBs from the Get With The Guidelines registry. And the top curve, you can see patients in red and the gray lines that either had their ACE or ARB discontinued during their hospitalization or not initiated. And those patients had nearly identical outcomes. Those curves you can see are overlapping. And patients that started ACE or ARB or continued therapy during their hospitalization, again, had very similar outcomes with significantly lower mortality at 1 year. On the right, there's data from the IMPACT registry that looked at use of beta blockers at 60 days post-discharge and looked at the percentage of patients that were on a beta blocker. So if you were started on a beta blocker during your hospital stay, you were much more likely to be on a beta blocker at 60 days. And similarly, if you were not initiated on a beta blocker during your hospitalization, it was much less likely to get started. And so hopefully all of this data is coming together to convince you that if you want your patient on guideline directed medical therapy as an outpatient, it's really important to start it as an inpatient. And I think that, this may seem intuitive, but I think that I can think of a lot of examples where I personally have said, well, as patients ready to go home, they can just start this therapy, as an outpatient. They have an outpatient cardiologist who can start this. And I think that always feels very reasonable at the time, although this data would suggest otherwise, that if you don't take this extra step and start medical therapy during the inpatient setting, patients are highly unlikely to get started at it. So this is kind of similar, but on the left, you can see beta blocker initiation, 60 to 90 days follow-up. In the blue, it's whether they were prescribed the beta blocker at hospital discharge, and in the right, it was not prescribed at discharge. So if you were prescribed a beta blocker at discharge, 93% of patients were on a beta blocker at 60 to 90 days, as opposed to only a third of patients that were not prescribed a beta blocker at discharge. And these numbers look very similar at 1 year with respect to ARNIs and MRAs. So the take-home point from all of this is that most patients are admitted for acute on chronic heart failure and volume overload, but not cardiogenic shock. And if that's the case, don't stop their beta blocker during their inpatient admission. It is much less likely to get restarted once they've left the hospital. Most worsening renal failure in the context of RAS inhibition reflects reversible intrarenal hemodynamic effects, not permanent reductions in kidney function. And it's acceptable to have moderate rises in creatinine and not discontinue RAS inhibitors. Because again, if these are discontinued during the hospitalization, it is highly unlikely that they get started after patients are discharged. So what do the guidelines say about this? Well, the guidelines say something very similar. It's a class 1 recommendation that in patients with heart failure with reduced ejection fraction experiencing symptomatic exacerbation requiring hospitalization during chronic maintenance therapy treatment, it is recommended that guideline medical therapy be continued, assuming that they're hemodynamically stable. And with respect to beta blockers specifically, again, a class 1 recommendation, initiation of beta blocker therapy is recommended after optimization of volume status and successful discontinuation of intravenous diuretics, vasodilators, and inotropic agents. Beta blocker therapy should be initiated at a low dose and only in stable patients. So again, all of that data applied to patients with acute on chronic heart failure during their hospitalization. But what do we have to offer for end stage heart failure patients? And that's really the population that you've heard so much today. So the lifestyle study was recently published and was designed after the Paradigm-HF study showed that Entresto improved morbidity and mortality in patients with chronic heart failure in comparison to enalapril. But Paradigm-HF had only 1%, or actually less than 1% of patients with class 4 heart failure. And so we really felt as a field that additional experience on tolerability and outcomes with Entresto was needed in this really advanced heart failure population, patients with class 4 heart failure. And so this was what the life study was designed to test the hypothesis that Entresto is superior to Valsartan with respect to lowering NT-proBNP levels in patients with advanced heart failure. So here you can see that there was no statistically significant difference in cardiovascular death or heart failure hospitalizations with Entresto in this really advanced cohort. And in fact, there were numerically greater adverse outcomes in the Entresto group. So what about vasodilators? So this is the Galactic study. And Galactic asked the question, does an approach of early, intensive, and sustained vasodilation improve outcomes in acute heart failure. And this was compared to usual care. So 781 patients were analyzed for a composite of all-cause mortality or rehospitalization for acute heart failure at 180 days. And there was no significant difference between the two groups. There was greater use of RAS antagonists at discharge, but not at 180 days of follow-up. And finally, there's limited data on intravenous nitrates and nitroprusside. So on the left, you can see freedom from all-cause mortality. And this was greater in patients that were treated with nitroprusside during their hospitalization. And so this may be appropriate in states of increased filling pressures and high SVR with close monitoring of blood pressure. So hopefully I've shown you here that in this acute heart failure population with really end-stage disease, we have very limited options in terms of what we can provide outside of advanced heart failure therapies. And so the focus here is on using inotropes and vasodilators. Here the data is for intravenous nitroprusside to stabilize the patient and get them to advanced therapies. And this is, again, the guidelines, just reiterating that. So what about some of the other structural therapies in this very advanced cohort? So there's little evidence that CRT can be used as a bailout strategy in non-ambulatory class 4 heart failure patients. Not to say that it perhaps doesn't work, although there's really no data to support that, with less than 4% of patients in CRT randomized controlled trials having class 4 heart failure. Similarly, there's no evidence that MitraClip is effective as a bailout strategy in class 4 heart failure. So in the COAPT trial, only 6% of patients receiving a MitraClip were NYHA class 4 ambulatory heart failure patients. So again, I think the message hopefully is that while we have lots of strategies for treating patients with acute decompensated heart failure that are not end stage, and there are very early and sustained benefits, there's very little that we can do for this group of class 4 heart failure. And the focus again is on stabilization and transitioning to heart failure advanced therapies if appropriate. So the take-home points here, most patients will be admitted for volume overload, not for cardiogenic shock. In these cases, you want to diurese these patients to decongestion, continue guideline-directed medical therapy in patients who are already being treated, and add guideline-directed medical therapy prior to discharge for those who have not been initiated on therapy. There are some patients, however, who will be admitted with low output cardiogenic shock, these class 4 patients that I talked about at the end. In these patients, you will stop their beta blocker and may need to discontinue RAS inhibitors, and a strategy of intravenous vasodilators such as nitroprusside may be necessary for stabilization of these patients. There's really little else we can offer in the way of structural therapies such as CRT or MitraClip. And at this point, it's really important to establish what patients' goals of care are. And if appropriate, these patients need to be stabilized and promptly referred for advanced therapies while continuing that process.